It's Ian, back with another head and neck anatomy video. Today we're covering cranial nerves, so let's get right into it. So the human nervous system can be subdivided into two nervous systems, the central nervous system, or the CNS, and the peripheral nervous system, or the PNS. The CNS can be divided into the brain, which includes the forebrain, midbrain, and hindbrain, and the spinal cord, which relays voluntary movements and conducts sensory information to the brain and motor information away from the brain. The PNS contains both sensory fibers and motor fibers and can be divided into the somatic nervous system, voluntary control, and the autonomic nervous system, involuntary control. The autonomic system includes actions involving involuntary control, like controlling your heartbeat or constriction of your pupils, and the somatic system is the voluntary control of muscles. And finally, the autonomic nervous system can be divided into the sympathetic and parasympathetic divisions. And I suppose you're wondering what all that means, so we're going to talk about the differences between the sympathetic division and the parasympathetic division. The sympathetic and parasympathetic nervous systems have opposing functions. The sympathetic nervous system is our fight or flight system that includes functions that help us move and stay alert. The parasympathetic nervous system is our rest and digest system that includes functions that are activated in states of rest and allow for stabilization of the body. Focusing on the fibers that make up these nervous systems, it's important to know that the sympathetic nervous system has short preganglionic fibers and long postganglionic fibers. And the parasympathetic nervous system is the opposite. It has long preganglionic fibers and short postganglionic fibers. But what does this mean, and why does this make sense? These terms are used in the context of the autonomic nervous system. The preganglionic fibers are nerves that originate from the central nervous system, brain or spinal cord, and extend out to ganglia, which are clusters of nerve cell bodies outside the central nervous system. Postganglionic fibers are nerve fibers that extend out from the ganglia to the target organs or tissues, such as the heart, lungs, or digestive system. The SNS, or the sympathetic nervous system, has much more widespread effects, and thus the synapses are near the vertebral column, so we can carry out fast effects. The parasympathetic nervous system has much more localized effects, and so its synapses farther away from the vertebral column and closer to the specific effector organ. Finally, because this presentation is about cranial nerves, it's important to mention that there are 4 cranial nerves with parasympathetic preganglionic fibers, and this is cranial nerves 3, 7, 9, and 10. We'll learn more about the specifics of these nerves, but for now know that these cranial nerves play a crucial role in regulating various autonomic functions, like controlling the pupils, salivation, lacrimation, and GI motility. So I just talked for a while, which is so unlike me. So let's break up this video with a little example question right in the middle. So example question 1. Which of the following is correct regarding the parasympathetic nervous system? So those are the choices. Take a second to think if you need it, but the answer is B. Long preganglionic and short postganglionic fibers. Remember, this is because the PNS has more localized effects, so its synapses farther away from the vertebral column and closer to the effector organ. Alright, now let's get into the meat and potatoes of this presentation. We have 12 cranial nerves, and we'll go through each nerve one by one and point out high-yield information along the way. Let's start off by listing these nerves. So the first one is olfactory, then optic, oculomotor, trochlear, and trigeminal. And then we have abducens and facial and vestibulocochlear. And then we have glossopharungeal, vagus, accessory, and hypoglossal. Now let's move on to the olfactory nerve. Okay, so for each nerve, where relevant, we'll discuss the nerve's location, pathway, modality, and function. So here's the olfactory nerve. It extends from the telencephalon. Here's the pathway. It's obviously a sensory nerve, and it functions to process smell. So this olfactory nerve, it extends from the telencephalon and travels via the olfactory nerve endings, highlighted in the image, through the olfactory epithelium, past the cribriform plate where the axons of the olfactory neuron meet at the olfactory bulb, down the olfactory tract, and to the primary cortex of the temporal lobe. The olfactory nerve is most likely to be injured in instances of head trauma because of its location within the cribriform plate, a very delicate structure within the skull. Thus, patients may present with anosmia or lack of smell following a traumatic motor vehicle accident or head injury. But I have grown tired of this nerve, and quite frankly it smells, so let's move on to the optic nerve. The optic nerve is a sensory nerve originating in the retina, and it transmits visual information from the retina to the brain. So here is the pathway for the optic nerve, alright? It crosses at the optic chiasm, where the neurons decussate, also known as crossover, to the lateral geniculate nucleus, and then finally the primary visual cortex of the occipital lobe. So obviously the modality of this nerve is sensory, and it functions for vision. And I also want to note that the optic nerve goes through the optic canal of the sphenoid bone. Now let's move on from this onto the oculomotor nerve. The oculomotor nerve is a motor nerve originating in the midbrain, and it travels through the superior orbital fissure to the eye to depress and intort the eye through the innervation of the levator palpebrae superioris, the superior rectus, the medial rectus, the inferior rectus, and the inferior oblique. And now we are moving on to the functions. So the oculomotor nerve innervates the muscles that elevate the eyelid, which are the levator palpebrae superioris, move the eye up, which is the superior rectus, medially, which is the medial rectus, down, the inferior rectus, and elevate and laterally rotate, which is the inferior oblique. So we'll discuss what each muscle does specifically later on. So we mentioned previously that the parasympathetic preganglionic fibers are cranial nerves 3, 7, 9, and 10. The specific parasympathetic functions of cranial nerve 3 include pupillary constriction and accommodation. And now we're moving on to the trochlear nerve. So the trochlear nerve is a motor nerve originating in the midbrain. And unlike most of the other cranial nerves, the trochlear nerve exits out of the posterior surface of the brainstem. It travels around the brainstem to reach the superior orbital fissure and innervates the superior oblique muscle to rotate the eye downward and outward. And now we're moving on to the trigeminal nerve. Now this is a very important concept, so we're going to break down the 3 branches of this nerve individually. So this nerve originates in the trigeminal ganglion in a depression of the temporal bone known as Meckel's cave, and has 3 branches that exit through different foramina of the skull. So the pathways vary, and the different branches are the ophthalmic, the maxillary, and the mandibular. So I'm going to discuss each of these branches separately, but it's important to know that the modality is mixed, and that the function is a sensation of the face, gingiva, teeth, and motor function for mastication. So let's break this down. Okay, let's start off with the V1 branch of the trigeminal nerve. This is known as the ophthalmic nerve, and it exits the skull via the superior orbital fissure. So the modality and function of this nerve are quite similar, with sensory and the function being sensation. Specifically, this nerve provides sensation to the scalp, the skin of the forehead, the upper eyelid, the cornea, the conjunctiva, the frontal sinus, the nasal cavity and nasopharynx, and parts of the meninges. Other functions include the corneal reflex, or reflexive blinking of the eyelids to protect the eye, and the conduction of pain signals allowing for the perception of pain in the upper face and eye. I can't believe how long this guy's been talking. The nerve, am I right? Anyways, the V2 branch of the trigeminal nerve is known as the maxillary nerve. And this is a sensory nerve that exits the skull via the foramen rotundum. And again, the modality is sensory and the function is sensation. So this innervates the lower eyelid, the side of the nose, the skin of the cheek, the upper lip, the upper teeth and gums, the maxillary sinus, the nasal cavity, and the palate and associated mucous membranes. Other functions include the nasal and labial reflexes and the alveolar nerves, which are branches that play a crucial role in providing sensory innervation to the teeth and surrounding structures in the upper maxilla. The maxillary nerve gives rise to the superior alveolar nerves, which innervate the upper teeth and surrounding tissues. These nerves provide sensory innervation to the maxillary teeth and their supporting structures. It's important to know that the alveolar nerves, superior and inferior, branch off of both V2 and V3 and are involved in the anesthetizing of teeth. These nerves also transmit pain after a 3rd molar extraction. Alright, we are moving on to the last part of the trigeminal nerve, that is the V3 branch of the trigeminal nerve, known as the mandibular nerve, and it is a mixed modality nerve that exits the skull via the foramen ovale. The modality is mixed, and you're going to want to look up from your phone for this next part because it is very high yield. It provides sensation to the chin. It's important to note that the chin is innervated by the mental nerve, which is most susceptible to damage via genioplasty. This can manifest as sensory disturbances or numbness in the lower lip and chin. Also provides sensation to the lower lip, lower gums, floor of the mouth, the anterior 2/3 of the tongue, sensation which only comes from the lingual nerve. Also the temporomandibular joint, or the TMJ, and this is also high yield because it is innervated by the auriculotemporal nerve, which receives sensory information from the joint. The motor function includes the innervation of the muscles of mastication, which includes the masseter, the temporalis, the medial, the lateral, and the pterygoids. Other muscles include the anterior digastric and the mylohyoid, which are involved in swallowing and neck movement. Additionally, cranial nerve V3 provides motor innervation to the tensor tympani muscle involved in dampening sounds, and the tensor velae palatini muscle involved in opening the auditory tube during swallowing or yawning. A final high-yield point to know is the mandibular nerve gives rise to the inferior alveolar nerve, which innervates the lower teeth and surrounding tissues. The inferior alveolar nerve travels through the mandibular canal to give rise to the mental nerve, which exits the mandible via the mental foramen to supply sensation to the chin, lower lip, and buccal gingiva. During genioplasty, improper surgical techniques or proximity to the mental foramen can damage the mental nerve, leading to numbness or altered sensation in these areas. Going one step further, an ineffective inferior alveolar nerve block could be attributed to mylohyoid ramification nerves not being adequately blocked. Other reasons are certainly possible, however, this is a high-yield piece of information to know for the exam. Alright, get it, got it, good. Let's move on to example question 2. Which symptom is least likely following lingual nerve injury? So the options are loss of taste of the anterior 2/3 of the tongue, loss of motor function, loss of general sensation, difficulty speaking or swallowing, and burning or shooting pain. And the answer is B, loss of motor function. So the lingual nerve is a purely sensory nerve, and as a result, an injury to the lingual nerve will manifest as a sensory dysfunction. Looking at option A, the lingual nerve carries the chorda tympani or cranial nerve 7 specialized taste fibers, so while it isn't directly responsible for taste, it does transmit signals to and from the brain. Option C isn't correct because of the reasons we just mentioned. The lingual nerve carries sensory information, so we would observe loss of general sensation following the lingual nerve injury. Option D is incorrect because loss of speaking and swallowing function is not typically caused by lingual nerve injury, as the lingual nerve is purely sensory. And option E is incorrect because burning and shooting pain can also be observed with a lingual nerve injury. Now let's move on to the Abducens nerve. So the Abducens nerve is a motor nerve originating in the pons, and it travels through the superior orbital fissure to the lateral rectus muscle, where this motor nerve functions to abduct the eye. Now let's move on to talking about the facial nerve. So the facial nerve is a mixed modality nerve originating in the pons, and the motor branch only travels through the stylomastoid foramen to innervate various structures and muscles of facial expression. Now moving on to the function of the facial nerve provides sensation to the ear and the tongue via the chorda tympani. Make sure to remember that the facial nerve carries taste sensation from the anterior 2/3 of the tongue via its chorda tympani branch. The facial nerve innervates various muscles of facial expression, such as the orbicularis oris, including the muscles of the forehead, eyes, nose, and mouth. It's important to remember that the facial nerve innervates the muscles of facial expression. The facial nerve also provides motor function to the posterior digastric, the stylohyoid, and the stapedius. And on top of all of this, the facial nerve also carries parasympathetic fibers to innervate glands such as the submandibular gland, the sublingual gland, the lacrimal gland, and the nasal glands. So there are 5 facial nerve branches: the temporal, the zygomatic, the buccal, the mandibular, and the cervical branches, which can be remembered from the mnemonic 10 zebras broke my car. There are 2 high-yield facts to know associated with the buccal branch specifically. First is that this branch courses adjacent to the facial artery, which is a branch of the external carotid artery, and is crucial for blood supply to the face muscles, skin, and soft tissue. Second is that the buccal branch is associated with the orbicularis oris innervation, thus allowing for voluntary movements including smiling, pouting, or whistling. So now we're going to move on, just kidding, still on the facial nerve. A high-yield pathology to know that is associated with the facial nerve is Bell's palsy. This condition is associated with facial muscle weakness or even a paralysis as a result of damage to the facial nerve. This can manifest as a failure to lift one side of one's face. Some clinical scenarios you might encounter include a patient being unable to close their right eye after receiving an injection in the right side of their mouth, or a patient reporting paresthesia of their eyelid after receiving an injection that was injected too far posterior. During a parotid gland surgery, the facial nerve is at risk of being severed as it passes through the gland, potentially leading to paralysis or weakness of the facial muscles on the affected side. And now that that's that, let's move on to example question 3. The temporalis muscle is innervated by which nerve? The facial nerve, the temporal nerve, the ophthalmic nerve, the auriculotemporal nerve, or the trigeminal nerve? Now take a moment if you need it, but the correct answer is E, the trigeminal nerve. The temporalis muscle is innervated by the trigeminal nerve. These nerves supply motor innervation to the temporalis muscle, allowing it to participate in such actions as jaw closure and chewing. And now we're moving on to, guess what, another nerve. The vestibulocochlear nerve is a sensory nerve originating in the inner ear. And this nerve travels through the internal acoustic meatus, where it travels towards the brainstem. The modality of this is sensory, and the functioning is hearing and balance, and once it gets to the brainstem, it synapses with nuclei involved in auditory and vestibular processing. Now we're moving on to the ninth cranial nerve, and that is the Glossopharungeal Nerve. It is a mixed modality nerve originating in the brainstem. So this nerve travels through the jugular foramen, where it gives off several branches, with the most notable ones being the tympanic nerve, which carries out sensory information from the middle ear, the carotid sinus nerve, which provides sensory innervation to the carotid sinus and body, and the pharyngeal branches, which innervate the muscles of the pharynx. And I jumped the gun a bit, describing that the modality was mixed, but I'm sure you guys are fine without the spoiler warning. And in terms of functions, the sensory functions of the nerve involve the innervation of the posterior one-third of the tongue, including taste via its lingual branch, pharynx, soft palate, tonsils, middle ear, and carotid sinus. So this nerve is also responsible for taste, alongside motor function, including swallowing, with the innervation of the stylopharyngeus. So a high yield fact to note is that the glossopharyngeal nerve is the afferent branch of the gag reflex. And it's also important to know that this nerve is responsible for preganglionic parasympathetic innervation of the parotoid gland. I hope you absorbed some of this information, because let's move on to example question 4. Which nerve carries the afferent information for the gag reflex? Well, I just mentioned this, so I hope you know it. The mandibular nerve, the Abducens nerve, the facial nerve, the vestibulocochlear nerve, or the glossopharungeal nerve. And the answer is, not surprising, it is the glossopharyngeal nerve. So reflexes have afferent and efferent components. Recall that afferent nerves carry sensory signals from receptors in the body to the central nervous system. In contrast, efferent nerves carry signals from the central nervous system to effector organs such as muscles or glands. The afferent component of the gag reflex is carried by the glossopharyngeal nerve, which, in addition to the gag reflex, is involved in swallowing, taste, sensation in the posterior third of the tongue, and alterations in blood pressure regulation. And I'm gambling on the fact that you guys are going to like this next nerve. That's right, it's the vagus nerve. What happens here stays here. So the vagus nerve originates in the medulla as it travels through the jugular foramen, where it exits alongside cranial nerve 9 and cranial nerve 11 to serve its function as a mixed modality nerve. The vagus nerve has extensive distribution throughout the body. It innervates structures in the head and neck region, including the pharynx, larynx, and various organs in the thoracic and abdominal cavities. It sends branches to the heart, lungs, esophagus, stomach, pancreas, liver, intestines, and other abdominal organs. The vagus nerve serves as the main parasympathetic nerve of the body, carrying parasympathetic fibers to many organs. It helps regulate involuntary processes and is often referred to as the wandering nerve due to its extensive distribution. It is especially important to note that the vagus nerve provides motor innervation to the palatoglossal muscle. Finally, the vagus nerve supplies the efferent branch of the gag reflex. And now we are moving on to the accessory nerve. So the accessory nerve is a nerve originating from two separate nuclei in the brainstem. The cranial part of the accessory nerve arises from the medulla, while the spinal part originates from the upper cervical spinal cord segments. After exiting the skull, the cranial part of the accessory nerve descends down into the neck, where it joins with the spinal part. The spinal part of the accessory nerve exits the skull through the foramen magnum, and then it travels down the spinal canal, emerging through the foramina of the upper cervical vertebrae. So the accessory nerve is a motor nerve that primarily innervates the trapezius and the sternocleidomastoid muscles in the neck. It supplies motor fibers to these muscles, controlling the movements of the head and shoulders. The cranial part of the accessory nerve also contributes to motor fibers to other muscles involved in swallowing and phonation, along with the vagus nerve. And now we're moving on to the 12th nerve. I know you thought we'd never get there, but we did. This is the hypoglossal nerve. It originates in the medulla and exits the skull via the hypoglossal canal of the occipital bone. Once outside the skull, the hypoglossal nerve travels anteriorly and inferiorly, running along the lateral aspect of the upper cervical vertebrae. It then branches out to innervate the intrinsic and extrinsic muscles of the tongue, which are responsible for movements such as tongue protrusion, retraction, and lateralization. The hypoglossal nerve is primarily a motor nerve, controlling voluntary movements of the tongue, including speech, swallowing, and chewing. Its location and pathway allow it to efficiently supply motor innervation to the muscles of the tongue. Alright, and now we're cooking with gas. Now that we've discussed each of the cranial nerves in detail, let's group them together in 4 easy-to-remember groups so you don't experience information overload. The proposed groups here help to chunk the cranial nerves based on similarities in function. This is not, however, the only way to group the nerves, so we encourage you to consolidate the nerves in a manner that best facilitates your understanding. So first we have cranial nerves 1, 2, and 8, primarily sensory functions originating directly from the brain instead of the brainstem. And then we have cranial nerves 3, 4, and 6, which are muscles that move the eye. And then we have cranial nerves 5, 7, 9, and 10, which are major cranial nerves with a sensory and motor components. And then lastly, we have cranial nerves 11 and 12, which are remaining cranial nerves that only move a few muscles each. So now we've consolidated the nerves, now let's consolidate the tongue. So here is an overview of the taste and somatic sensation innervation of the tongue summarized in one figure. For the motor innervation of the tongue, it makes a lot of sense that the glossopharungeal and vagus nerve controls the muscles behind the tongue, where the hypoglossal nerve controls the motor movements of the entire tongue. Next, we're going to talk about taste and sensation. The vagus nerve innervates both the taste and sensation behind the tongue. Meanwhile, the taste and sensory of the posterior one-third of the tongue are both innervated by the glossopharungeal nerve. However, the taste for the anterior two-thirds of the tongue is innervated by the facial nerve, but sensory for the anterior two-thirds of the tongue is innervated by the mandibular branch of the trigeminal nerve. So make sure you keep these differences in mind. For the anterior two-thirds, taste is facial, but sensory is trigeminal. Nerves involved in dysphagia include cranial nerve 7, which is facial, 9, which is glossopharungeal, 10, which is vagus, and 12, which is hypoglossal, as they control the muscles responsible for swallowing and coordinating oral, pharyngeal, and esophageal phases. Now, I bet you guys can see where this is going. That's right, we're going to do a summary of the innervation of the eye. So to start this off, we're going to need to do a zoom in on our friend Mr. Bones, where we're going to do a quick recap of the muscles. So we have the superior rectus, the inferior oblique, the medial rectus, the superior oblique, the lateral rectus, and the levator palpebrae superioris. Now let's go back to the superior rectus muscle, which is innervated by cranial nerve 3, the oculomotor nerve, which elevates and intorts the eye. And then on the other side of the eye, we have the inferior rectus, which is innervated by cranial nerve 3, the oculomotor nerve, and it depresses the eye, causing the downgaze. And then we have the inferior oblique muscle, which, guess what, is innervated by cranial nerve 3, the oculomotor nerve, which elevates and abducts the eye. So abducts means to laterally move the eyeball. And then we're moving on to the medial rectus. And this muscle is, guess what, innervated by cranial nerve 3, the oculomotor nerve. And it is an adductor muscle, which means that it moves the eye medially. It moves the eye from side to side with the lateral rectus, an abductor muscle that moves the eye laterally. And now we're moving on to the superior oblique muscle, which is innervated not by cranial nerve 3, but by cranial nerve 4, the trochlear nerve, which moves the eye in the down and out position. Then, of course, we have the lateral rectus, which is innervated by cranial nerve 6, the Abducens nerve, and abducts the eye laterally. Now, I know you guys desperately wanted to forget about the levator palpebrae superioris, which is innervated by cranial nerve 3 and lifts our eyelids. Now, on the topic of the eye, we should talk about 3 intrinsic eye muscles that function to change the amount of light entering the eye, which is either innervated by the oculomotor nerve, cranial nerve 3, or the ophthalmic branch of the trigeminal nerve, which is cranial nerve 5. Let's focus on each intrinsic eye muscle and their action and innervation. So diving into the muscles of the eye, the first muscle we're going to talk about is the dilator pupillae. This muscle is innervated by postganglionic sympathetic fibers that travel alongside branches of the ophthalmic division of the trigeminal nerve. This makes sense because in a sympathetic fight or flight scenario, we need to dilate our eyes to see more. So here we can see the muscle dilating the pupil. So next we're going to talk about the sphincter pupillae, which is kind of the opposite of the dilator pupillae in the sense that it constricts the pupil. This is innervated by the parasympathetic short ciliary nerve fibers of the oculomotor nerve, which is cranial nerve 3. This also makes sense because in a parasympathetic rest and digest scenario, we require less light and can constrict our pupils. And finally, we're going to move on to the ciliary muscles, which is a smooth muscle that contracts to make the lens more spherical in near sight accommodation. This does not impact the pupil size like the other two do. It is innervated by parasympathetic short ciliary nerve fibers of the oculomotor nerve. So I know that was a lot of eye information coming at you all at once, so I put the information into a chart. Okay, we have the dilator pupillae. This muscle, which dilates the pupil, receives sympathetic innervation that travels alongside the branches of the trigeminal nerve, which is cranial nerve 5. And then we have the sphincter pupillae, which constricts the pupil, and the innervation is parasympathetic from the oculomotor nerve and the ciliary ganglion. And then we have the ciliary muscle, which rounds the lens to accommodate for near vision, and the innervation is the same as the sphincter pupillae. And then I have one last chart for you, which is an overview of the taste and somatic sensation innervation of the tongue summarized in one figure. And we got some mnemonics here too. So the 12 cranial nerves: olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharungeal, vagus, accessory, and hypoglossal. So the words are, oh, once one takes the anatomy final, very good vacations are heavenly. which sounds Shakespearean but may be helpful to remember the cranial nerve names. And then we have the cranial nerve types, which can be remembered via some say money matters, but my brother says big brains matter most. And if you don't have a brother, well, that doesn't apply to you. Looks like you're gonna fail. Anyways, let's move on to a summary of everything that we talked about today. So we did a nervous system overview, we talked about the cranial nerve functions, and we did some memory aids. Thank you so much.